Thanks, Pankaj, for that very kind introduction. And hello, everyone. It's an honor and a pleasure to be here today. Really enjoying the conference so far. I want to say the weather might not be as kind, but the warm hospitality of the Swedish people has been awesome since I've been here. And I bring warm greetings from Boston, my hometown, as well as from our institute, Tufts Medicine. And on behalf of the group there, I would love to talk about the environmental exposures in neonates. When Akhil asked me to pick a topic to talk about today here, my thought was, what am I working on currently that can have a big impact from everybody that's present within the room? And something that may be thought-provoking, something that you can take home with you. I have no disclosures relevant to this presentation, and really my objectives are to kind of do a summary of the current toxic exposures occurring in the newborns, very quickly go over the pathophysiological impacts, and to identify some mitigation strategies. So just as a background, technological advances have definitely improved survival of critically ill both term and preterm infants. While survival has improved, we all know that the long-term growth and neurocognitive outcomes, they really still carry a lot of significant morbidities into childhood as well as adulthood. The improved critical care therapeutics and environment, they pose a very unique challenge to exposure of multiple toxins and could potentially contribute partly to the negative growth and neurocognitive outcomes. So as health professionals, and more importantly, the policymakers, they really need to be aware of these often unrecognized, but definitely modifiable risk factors to make the needle move towards improved neonatal health. You know, we all talk about adverse childhood events that have long-term impact into adulthood. I would ask this audience to start thinking more about adverse neonatal events that impact the patients that we take care of. We start seeing our patients right somewhere here within this 22 to 24 week mark, where a lot of neural growth still has to happen. So exposures during this time frame will have an impact in the long term. So in the next few slides, I'll try to focus on the multiple exposures that our babies are seeing, whether they are born at term, critically ill, or preterm in the neonatal care environment, the PICU environment. So starting off, we briefly heard yesterday from Dr. Bodisetti about the excipients that are present in the neonatal formulation. So one of the things that we all need to pay a little bit more attention is to the toxins that are coming through the medications that we are routinely administering to our babies. We know that the hospitalized neonates are exposed to multiple medications with a median of about 9 unique medications per infant. Of the 50 most common medications used in the ELBW infants, only about 40% are approved by FDA in the US. There are definite economic, ethical, and practical barriers to studying new medications in the neonatal population, and this really results in inappropriate extrapolation of medication use from other populations such as older children and adults. There have been several notable examples of antibiotics, the most common medication class that is used in the NICU, which has resulted in unintended negative consequence. And one of the most common examples is the high-dose chloramphenicol that was commonly used in the 1960s and was discontinued once the toxic effects were identified, but not until after many kids had been exposed to it. The use of liquid and IV formulations increase the need for preservatives to avoid contamination, and the excipients, mainly the solvents, the vehicles, emulsifiers, preservatives that we are using to serve as a medium for those medications. However, despite the common use of preservatives and excipients in the neonatal medication, really little is known or published about the short and long-term effects of these agents. Moving on, all of us do x-rays. Fellows specifically love the 5 a.m. x-rays on a chronically intubated kid to make sure the tube is in the right place. Neonates admitted to the NICU are routinely exposed to radiation due to multiple diagnostic radiographic procedures that are needed. I'm not saying they're not needed, but we could be a little bit more judicious about their use. In a study, preterm infants weighing less than 750 grams were shown to be exposed to as many as an average of 30 films within the first 6 weeks of life. The brain now is being exposed to ionizing radiation at a time when neurogenesis, synaptogenesis, and myelination are at their peak. Additionally, radiation sensitivity is highest in the newborn period than at any other time in life, and this is because of the high mitotic activity as well as the small size, making these infants much more vulnerable. We all know about the biologic effects of radiation. They include radiation dermatitis, cataracts, infertility, organ atrophy or fibrosis, cancer, as well as the teratogenic effects. Often thought about but neglected arm is the sensory exposures and sensory deprivation. They go hand in hand. We all know about the healing touch. We all know about the calm environment that we need to get better when we're not feeling well, right? We want to be left alone, not bothered. Having said that, the sensory stimulation, which we know is critical for physical and mental health and well-being, and this includes all the 5 senses. They include touch, taste, smell, light, and sound. The sensory perceptual alterations can impact physical and mental well-being with irritability, restlessness, changes in mental status, as well as behavioral manifestations like anxiety, depression, psychosis. And a new field is starting to emerge about neonatal psychosis. I'm not sure how many of you are aware of it, but that is a very hot button topic for the child psychiatry group in our world. The NICU environment, we know, it has scenarios wherein there are both extremes of excessive sensory exposures as well as positive sensory experience deprivations. The ambient noise level in NICU can easily exceed the recommended levels of less than 45 decibels that has been shown by the AAP, or recommended by the AAP. Noise levels exceeding these ranges manifest as physiological signs of cardiorespiratory dysregulation, disturbed sleep, and impaired tactile learning with subsequent long-term consequences. Additionally, the noxic stimuli such as tactile, taste, smell, light, they constantly occur for these critically ill infants, often go unnoticed, and are associated with negative neurodevelopmental as well as behavioral outcomes. For preterm infants, an increasing number of stressors are known to be associated with regional alterations in the brain structure and function. Milk, right? Enteral nutrition. We strive to start it right as soon as after the babies are born to try to get them off of the more toxic parenteral nutrition, but that also comes with some risks. Progressive industrialization has definitely had its unintended consequences on human health because of exposure to the endocrine disrupting chemicals or EDCs. Fetal and neonatal exposures, they occur passively through placenta and breast milk. These exposures persist beyond the fetal life through both maternal breast milk as well as formula feedings, despite prohibition of certain chemical agent uses. Both these very vital enteral sources of nutrition are known to contain metals, pesticides, mycotoxins, packaging materials, and others. Pesticides, we know, have for long been known to cause disruptions at the cellular level with increased teratogenic as well as carcinogenic effects. A comparative study identified similar rates of presence of organo-inorganic agglomerates in both breast milk and formula. The only difference being that the larger size of these agglomerates weren't found in the formula, and that's likely because of the packaging material used for the formula products. Microplastics are ubiquitous with human exposures through ingestion, inhalation, and dermal contact, and have been constantly identified as being present in human breast milk. So much as we want to promote human breast milk, we also need to figure out a way wherein we can maybe measure or label the commercially available products. Maternal breast milk, difficult to look at. But when we are holding the formula makers to a standard of putting the concentrations on the label that's out there, it behooves the commercial human milk product companies to do the same. Heavy metal and other toxins in blood products. Approximately 9 out of 10 ELBW infants and 2/3 of the VLBW infants are going to be exposed to blood products, and these include the packed red cells, platelets, fresh frozen plasma, cryoprecipitates, IVIG, and others. Blood transfusions, we heard a lot about it from Dr. Lagama this morning, but we know that they can also be a substantial source of environmental toxins, which can bioaccumulate in the vascular system, leading to poor neurodevelopmental outcomes. Multi-organ damage, carcinogenic potential, and mortality have also been reported. The most studied or identified toxic materials or metals are lead, mercury, arsenic, and cadmium. WHO reported that lead alone has been reported as a neurotoxin responsible for about 2 million lives lost globally, having a significant impact on neurocognitive and neurobehavioral outcomes. Lead has the ability to replace calcium in the body and thus target multiple organ systems. Uniquely, it can remain in bone for years and can get released back in the system when demineralization occurs, attributing 1/3 of the global burden of idiopathic intellectual disability. In one of the works that we did, we were concerned about the lead load that the babies were getting from the PRBC transfusion in the NICU. And in that subset of patients, we tested each of the donor aliquot that the baby was getting to identify the lead load to begin with. We did the pre-transfusion and post-transfusion lead level for all the babies. And that happened for every single transfusion during the entire stay in the NICU. What we noted was that for each microdeciliter of lead level in the donor aliquot, the levels were, for the babies, would go up by 0.2 microgram per deciliter. Now, mind you, we used to say that a blood lead level of less than 5 was acceptable. However, that policy has changed, and at this point, AAP recommends no blood level as a safe lead level. What was really worrisome for us was that for one of the donor aliquots, the lead level was at about 50 micrograms per deciliter, and the post-transfusion lead level for the infant was in the 70s. Now, many of us like to save the given donor for about, the 60 days life that the donor pool is there to minimize donor exposure. Fortunately for this baby, because we were not blinded to the lead levels, we were able to prevent further transfusion from the same donor. Though my biggest regret is we couldn't go back to the donor and say, hey, look, you are suffering lead intoxication and you need to get treated. More importantly, a well-intentioned individual who's donating blood over and over again is exposing many more subjects or patients to this high lead level. Arsenic is another heavy metal that has been studied well and is known to be an epigenetic dysregulator, a carcinogen, and is responsible for endocrine disorders. The transfusion-transmitted infection rates have declined, but there still remains a real risk to the recipients of infection through the blood transfusion. In 2020, The NHSN, the hemovigilance module, reported that about 0.68 TTIs per 100,000 transfused components. So it's not unknown or it's not insignificant. And lastly, I want to focus a bit on plastics exposure. Neonates in the NICU have been exposed to DEPH and BPA, parabens, and other harmful plastics. The two most common plastics that neonates are exposed to are the phthalates and BPAs that are found in the medical devices. They are known to be carcinogenic, mutagenic, and endocrine disruptors. Phthalates like DEHP have been identified as potential endocrine disruptors. They disrupt the thyroid signaling pathway, which then results in growth, development, and tissue differentiation impairments. High concentration of BPA and parabens are found in the feeding tubes, the sterile gloves we use, the single lumen umbilical catheters, with the highest concentration of BPA found in the three-way stopcock. Urine analysis in infants have demonstrated that blood transfusions, mechanical ventilation, and high to moderate medical device exposures were associated with higher concentration of the plastic metabolites. So it's pretty clear, right? These babies who are with us in the NICU for 3 to 4 months, or even term infants who have congenital heart disease, are going through ECMO or other device exposures, are at significant risk for ongoing added exposures, right? They are the ones that are getting transfused. They are the ones who are on the ventilators. They are the ones who have devices sitting in them for a very long time. So what can be done? When we're thinking about the medication exposures, the most common concerns are the benzyl alcohol, the propylene glycol, and the ethanol content of these medications. And really the simple answer would be, why can we not take them out and have clinical trials with neonatal specific formulations? It's easier said than done. We do have formulations that are alcohol-free, but the cost of those medications when compared to the currently existing medications is much higher. So the adoption by the healthcare system of these agents, like, there is a formulation of phenobarbital that does not have alcohol in it, but I have not been able to convince my pharmacy to bring it on board because the cost difference is significant. So how do we create or have formularies that are safe but yet affordable? When we think about diagnostic exposures, trying to minimize the X-ray exposures overall, only get X-rays when you really are going to make a clinical decision based upon that film. POCUS has definitely taken on a lot more in Europe than in US. It's emerging, and we are trying to do more ultrasounds rather than X-rays. Proper X-ray positioning so that we are not doing scatter radiation in a common bay NICU environment where there are babies that are sitting closer to the baby that you're getting the X-ray for. And definitely avoid CT imaging in newborns. Sensory overload and or deprivation, we definitely can work easily on getting the ambient noise level down to less than 45 decibels, NICU design strategies, clustering care, reducing unnecessary alarms, limiting painful procedures and using analgesia when necessary, music therapies, having the occupational therapist, physical therapist providing that healing touch, most importantly, having the parents at the bedside. Kangaroo medical care in these settings actually helps both the parental anxiety and depression in some of the work we've done, but more importantly, it's very helpful for the babies. And then, the single NICU room concept is great. But the disparities that exist in the parents with their physical presence at the bedside makes a huge difference. Dr. Inder in some of her work showed that single-room NICUs could have a negative impact on neurodevelopmental outcome. which actually was shown not to be true, because if the parents are present in that single room, then the outcomes are definitely way better, because they are able to do more skin-to-skin care, breastfeed their babies, be available to be the soothing presence during those painful procedures. So the single room concept is great, but it has to be taken in the concept of the socioeconomic status or presence of the families. Nutrition, breast milk, and formula, as I mentioned, we definitely want to limit the release environment, because it doesn't matter whether I'm from a high socioeconomic status or I'm coming from an LMIC. The exposures are the same. If the ambient air or the air quality index is not good, then that mother is going to be transmitting these agents through the fetal period, as well as postnatally during the breastfeeding phase. Limit the introduction within the formula manufacturing packaging processes, and reporting these levels in commercial preparations. We have to hold the donor breast milk companies or the commercially available products to the same standard that we hold the formula companies to, which is a big one in my mind. Blood product exposures, again, continue to very successfully screen, use the screening efforts we have. One of my, biggest failures have been, I've been going to my individual blood banks to say, can you just screen the donor for their lead level? Such a simple test, such a cost-effective test that can prevent exposure, but somehow the transfusion medicine world is a world of its own. And so just being aware of it is important. And then we know that the leukoreduction process does reduce the infectious transmission risks, most importantly CMV. For bacterial contamination, UV treatment of the product and primary and secondary testing is helpful. For the heavy metals, again, limiting the release in environment, pre-post transfusion testing to allocate a less contaminated product to the newborns could make a bit of a difference. And then for devices, I call on to the entrepreneurs and the scientists in the audience to think of what are the alternatives to the devices that we are using. How can we get these plastics, the DEHPs, the BPAs out of these tubes and devices that these babies are living for up to 3 to 4 months. And with that, I would like to conclude to say that a concerted effort focusing on eliminating toxic and harmful substances from commercial products is critical in neonatal care, and alternatives should be made available. Resource allocation is needed by community leaders and health policy makers through regulation and incentives to ensure that neonates and children can have a healthy, happy, and productive lives. Our society really should be judged by how we care for and treat this most vulnerable population who deserve environments and treatments free from unintended and unnecessary harmful exposures. And with that, these are my references. I do thank you for your kind attention and happy to answer any questions.